Hello everyone, are you all able to hear me okay? So I'd like to start by welcoming you all to part one of the Why Endocrinology and Diabetes webinar series. And I'd like to thank you all very much for signing in today, despite the difficult circumstances that we're experiencing worldwide right now. So as many of you will know, that this is actually our fourth taster day in diabetes and endocrinology, but our very first webinar series. And we've got some excellent speakers lined up for you today who are going to talk to us about why they chose to pursue a career in endocrinology, and will give us some useful clinical and practical tips on sort of typical aspects that you will all see in clinical endocrinology that will help us all get through our common endocrine situations that we all face. We are keen to keep the session interactive, despite it being a webinar series. And so please could I request that you all put your questions into the web chat, and I'll direct them towards the speakers during the Q&A session in the last 15 minutes or so of the webinar series today. A reminder to all the speakers that if you could kindly keep your videos and mics off when you're not speaking, just to sort of minimize the background noise that we hear. And without, I'd like to swiftly now move on to introducing our first speaker. So it gives me great pleasure to introduce Dr. Helen Simpson, who's a consultant endocrinologist at UCLH. And as well as working in clinical endocrinology, Dr. Simpson partakes in a number of other endocrine-related activities, including working closely with patient support groups, and has recently put in a lot of time into launching the National Emergency Steroid Card. And today she's going to share not only her tips on how to pursue a career in endocrinology, but also top tips on steroid safety and management of sodium. So Dr. Simpson, thank you very much for joining us today.
Thank you, Shaz. Oh, let me share my screen. Ooh. So thank you for inviting me to talk to you about endocrinology, which is very easy because it is just the best medical specialty. And my slide's moving. Yeah, as you can see, I do a lot of other things. So I'd like to think I help the Society for Endocrinology. I'm part of the Royal College of Physicians Patient Safety Committee. I've been an expert advisor for Macmillan and do stuff around late effects, and a trustee for the Addison's Disease Self-Help Group. And I'm also an EPIC user, so I've been involved in our electronic patient record. And I'm actually in Devon and Exeter at the moment with a go live for EPIC. So you can see there's an opportunity to have a varied career. So a little bit about my journey. I started off as an undergraduate at Cambridge and went to the London Hospital as a clinical student. I can say my academic career as an undergraduate was completely indistinguished or undistinguished, and I failed exams for the first time ever. So don't be put off, just keep going. I did make some of my forever friends. So I'm staying with my friend Helen at the moment. At the London, I just had a fantastic time, and I just developed a love of clinical medicine from my first day of the wards with Professor Cohen at Mile End Hospital. And I asked so many questions. I think the registrar thought I was a complete pain in the arse from a very early age. But I really love clinical medicine, and the London is a very special place to me still. I then moved for my specialist training to St Thomas's, and that's because an opportunity came up. And there I spent, again, a very happy time. I worked with Professor Peter Sonksen, and Margaret Umpleby was my PhD supervisor, and Richard Jones as well. And we getting through the Friday lunchtime meetings there. This was my research protocol, which was a hyperinsulinemic euglycemic clamp. And I really understood the physiology of hormones. So growth hormone, insulin, and IGF-1, as I'll show in a little bit, really understand the basic physiology, how hormones do what they did. I traveled a lot during this time. This is work travel, so Kuala Lumpur, San Francisco, Hong Kong. This is Gothenburg. No, sorry, that's Copenhagen, Gothenburg. And so I had this opportunity from research to do quite a lot of other things, but also stay in a clinic for a long time to learn about looking after patients with long-term conditions and how they affected people's lives. I then moved on to Cambridge, first as a senior clinical fellow, then as a consultant. And there I we had the opportunity really to, I suppose, was the icing on the cake for my training. Oops, lost a slide, sorry. And I worked with loads of different people, as you can see, but this was really because we set up lots of different services. I set up a neuroendocrine tumour service across the region. I learned how to do ultrasound guided biopsies. I did ward work. I did all sorts of different things. And really in that time, I had a fantastic clinical experience, which I think really was a really great time to kind of really develop my skills. I then moved to UCLH here. Now I think I'm in the early part of my UCLH career, and here I'm developing things about transition, working with new people, young adult patients, and late effects, as well as doing other activities such as Royal College of Physicians. So why I love endocrinology is because hormones, they control everything that we do. There isn't any other system really that has such wide-reaching effects, and we know this from the patients we look after in our clinics. And so I'm going to talk to you a little bit about the posterior pituitary and a little bit about the adrenal glands. So this was a patient who had acromegaly, which is a tumour making too much growth hormone. And for those of you who aren't differentiated, this is the tumour here in the pituitary, and you can see here, it's quite a discrete thing. And so she had a transfemoral operation to remove it, and it was an uncomplicated procedure, and went home, was completely fine. She then came in the next day about 3 days later with nausea, vomiting. There was a little bit of a story that she'd had a meal from the fridge and may have some food poisoning. So she was given a little bit of fluid, but you can see here she had a very high urinary sodium and a high urine osmolality. And so the diagnosis here was syndrome of inappropriate ADH secretion. This is just a lot of numbers really, but this is, again, shows you why I really enjoy being an endocrinologist, because if we look at the physiology, we can see what's happening with our patients, and then we can understand how to treat them. So this is where she came in here, and you can see very high urine sodium and a high urine osmolality here. And that was because of the inappropriate ADH secretion or vasopressin meant that she wasn't peeing very much urine and was basically water overloaded to drop her sodium. And you can see here what we did with this patient was that we actually measured the copeptin, which is a marker of vasopressin. So you can see when she was fine, she had an undetectable copeptin, but here she had a very inappropriately measurable and then raised copeptin later on while she had a low sodium. And so you can see here that this is the physiology is telling us what's happening. She wasn't excreting her free water, so we fluid restricted her to 500 mils a day. This is her fluid intake here. 500 mils a day, and we gave her hypertonic saline, which is 5% saline that we used in Cambridge at that time. So we gave her some very salty water, fluid restricted her, and then you can see here as a really nice way of seeing that she was recovering. We looked at her urine output, so you can see here she didn't pee that much. Then all of a sudden on this day you can see she got a diuresis. So she peed out all her excess water, and this was all secondary to her neurosurgical operation. You can see here, after peeing this out, basically her sodium went up. So this is a really nice description to help us looking at the physiology to help our patients. And that's really one of the reasons why I really love endocrinology. If you want to read more about this, is a lovely example of how we can use this and diagnose, manage our patients in clinical endocrinology, Endocrine Connections by Steve Ball. And this again shows us how to safely use hypertonic saline. In terms of steroids, so again here, this was a patient, going back to our patient, this was a 24-year-old male who presented with unwell with abdominal pain, had nausea, weight loss, and feeling a bit dizzy at times over the last year. He noticed he was tanning easily, had a recent dental infection needing tooth extraction, and came to the emergency department. So if you like, one of the signs here that this guy was feeling really unwell was that he came to the emergency department as a young person. And so this dental infection, it basically precipitated him what was going on. He looked very unwell, he was hypotensive, he was tachycardic, and clinically he was volume deplete. This isn't his pictures, but you can see here the classic pigmentation of the skin, and this was a white-skinned person, and this is a presentation of someone with Addison's disease. And you can see here a good place to look also in people who've got darker skins is looking at the buccal pigmentation here, and also in surgical scars. And another trick is to ask people or family to bring in old photographs and see whether you can see any difference in the skin colour there. Labs showed a hemoglobin was fine, a slight neutrophilia, which you can often see in this presentation, and it shouldn't be confused with appendicitis. And then in the olden days, some people ended up going off for surgery. He had a classical picture of hyponatremia and hyperkalemia, consistent with the mineralocorticoid deficiency we see in Addison's disease, and also a high urea and high creatinine consistent with acute kidney injury. cortisol was low, and then you can also see had a blunted response to Senacthin with a high ACTH. So if you see a patient, you suspect adrenal insufficiency, and just remembering that secondary adrenal insufficiency patients won't be pigmented. So people with hypothalamic or pituitary disease, or people on exogenous steroids with HPA axis suppression, they won't be pigmented. But if you're suspecting it in any patient, take a cortisol. ACTH is great, but it has to be an EDTA on ice. So you may not get that on call, and don't worry. But do not delay treatment whilst waiting for results. So that's really the clinical take-home message. In terms of treatment, then this is what we're sharing at the moment in this guidance that we've published, and also is on the back of the steroid emergency card I'll show you in a minute, is to give some IM or IV hydrocortisone, whichever you can, followed by 200 milligrams continuously over 24 hours IV. But if you can't do that, 50 milligrams 6-hourly IM or IV in a close monitoring environment, and don't omit any doses. This is the key, is just basically give hydrocortisone, give plenty, and make sure it's given. Patients in an adrenal crisis or a new presentation will need a lot of fluid, but just double check the sodium's okay first. If they've got severe hyponatremia, again, don't overload them with too much fluid. And as they get better, you can gradually wean down. So again, that's an acute adrenal presentation. And the reason, again, I enjoy endocrinology is that, again, if we look at our negative feedback loops and the underlying physiology, we can work out how to treat our patients and what's going on. So again, thinking about the hypothalamic pituitary adrenal axis, we've got the hypothalamus and the pituitary up here, hypothalamus up here, and that makes CRH, that makes POMC, that splits into the ACTH that stimulates the adrenals to make cortisol, amongst other things. But you can also see it makes it alpha MSH, and that's what causes the pigmentation. So all that physiology we learned does come in useful in clinical practice. Cortisol itself is involved in a negative feedback loop, and this is how the whole system stays in sync. So with Addison's, where the adrenals aren't making any cortisol, the hypothalamus and pituitary sense that, so they make ACTH, which goes up, as in our patients. It's like the accelerator in the car. It's saying to the adrenals, work harder, work harder, work harder, and they can't. But this is how we can make our diagnosis from the blood tests. Just to remember, exogenous steroids also cause the HPA axis suppression. And also the adrenals emit aldosterone, cortisol, and androgens at different levels. And so why is this important? Well, I had this slide shared by Simon Pierce, and it's because our patients are dying. And this was there's been 2 young people recently, in the last few years, who've died as a result of the Addisons being missed. And so because of this, and I'll show you a little bit more about this as we go on, I've been involved also at some system level work to try and improve safety on a wider scale than we do in our clinic in outpatients. And so there's been 3 pieces of work that have been going on. And this is National Patient Safety Alert, which, if you like, is an organisational level, clinical guidance, which is at our level, so the healthcare professional level, the NHS Steroid Emergency card at the patient level. So I've been really thinking a lot more about how we can change things maybe on a slightly bigger level, as I say, than just sitting in clinic with a patient. So this was the National Patient Safety Alert that went live in August of this year, and this goes out to everybody across the NHS, including the devolved nations. So acute trust, private providers, mental health trust, community trust, GPs, community pharmacists. And this is because, as well as we know that these deaths in adults, there's been 4 deaths and 4 patients admitted to critical care for steroids basically omitted in hospital. So people having operations and a septic, it was missed. And this is a mixture of people on exogenous steroids for other causes and people with endocrine disease, and 320 other incidents were described, and we know that's likely the tip of the iceberg. So because of the because of this alert, this has gone to everyone, and it's now should be working its way through all our patient safety committees in our hospitals. And so one thing we can all do is get engaged and help this process and offer education to colleagues as needed. So in order to give people some of the tools that might be helpful, there's these 2 pieces of guidance. So this is the perioperative management of patients with adrenal insufficiency, and this is our clinical guidance for more medical issues, but it's got a little bit about surgery as well, and hopefully there's some summary and slides in there that you might find useful in management when you're teaching colleagues or for reading yourselves. And then the last thing, which may only look little, it's only a little piece of non-laminated card. So, but this, many people have been working on this for several years, so including Vibka Art and John Wass, and then latterly myself, leading this as the senior clinical advisor, together with the Royal College of Physicians, NHS England, Improvement Patient Safety, and together brought out this card. And with 600,000 of these have been ordered now. And you can see here that the patient carries it, so it's not very high tech, but actually patients are still loving it, and it can be downloaded as a PDF onto their phones. A bit of information here about why steroids mustn't be omitted. A bit of information here about words to use when you call 999 or 111. And here you've got the emergency management here of adrenal crisis. The QR code scans to the Society for Endocrinology webpage, so there's more information if needed. And so if you thought I'd ever be working on something like this when I was a student, a registrar, or even a junior consultant, I'd really enjoyed this opportunity to really look at things in a kind of different way. So I was asked when we had our remit for this, what am I most proud of, or some of my achievements. So as I've mentioned, the steroid card, I just really hope this makes a difference for patients, because this is really what we are all here for. I'm really proud that I finished my PhD. Even though the PhD isn't a be-all and end-all, for me, I found it really difficult because I had a baby, I was a medical registrar on call, and there were some days I never thought it would finish. And then I, in fact, even ended up getting the best paper in JCNM one year, and I think in ancient history, actually, in 2004. And so I'm actually very proud of this, although I often forget about it. And the other thing I'm clearly very proud of is that I grew a teenager. And again, this just shows us what hormones do, because I remember not so long ago he was actually a baby, and now look, he's 17 and this big. So why do I like endocrinology? So it's for my patients, and it's because of the people that I come across in all sorts of different ways as colleagues, patient support groups and societies. So again, this is another very memorable patient that I looked after and still look after, in that she had presented 35 weeks pregnant with a severe chromocytoma that's about 11 centimeters in size. She had an adrenal crisis in the emergency section, sorry, not adrenal crisis, a severe chromocytoma crisis, and had a crash section. She then had another 3 weeks before she had a laparotomy to remove this lesion. And then she had some lymph nodes and then had another operation. And so she actually, I looked after her at Cambridge and has followed me to UCLH. So we have great long-term relationships with our patients and really can get to know them well. And then all the people that we work with. So this is people that were attending the Society for Endocrinology BES last year. And sadly, we won't meet each other this year, but I'm sure we will in the future. And they really make a huge difference. And I think Claire Higham on here somewhere. I don't think I have Carla, but these people I really enjoy working with. And I think I really gain in clinical practice from their knowledge and experience too. So I think that's really all I have to say, apart from, I think we're asked for top tips. And I think my tips are, careers are not linear. I've gone in a bit of a squiggly way, and I think each level, I think I've enjoyed things that are slightly different. Other things to maybe think about are getting a mentor or a coach, and find your own voice and do what is right for you. I mean, people will say you have to do this, this, and this, and that's just totally not true. Just find out what's right, find out what's for you, and find someone you can talk to if you're finding you have difficult decisions to make. So that's me, and I hope you enjoyed that, and we'll take any questions later on. You're right, Shaz.
Yep, I think I'm on now. So brilliant. Thank you so much for that, Dr. Simpson. Your passion for endocrinology clearly has shone through, as has your commitment to patient safety. So incredibly admirable, everything that you've done so far and you continue to do. And what you didn't mention in your talk was that you are very active on Twitter. And so if anybody would like to hear and see more of what Dr. Simpson does, I suggest you just search her Twitter handle, and I'm sure you'll find some very interesting stuff there. A reminder to all of our attendees, please do submit your questions via the chat box, and I've seen there's a few questions pop up already, and I will make a note and discuss them in the question and answer session at the end. So our second speaker today is Dr. Claire Hyen. She is an endocrinologist working at the Christie Hospital in Manchester after having completed her medical training in London, in fact at the Royal Free and UCLH. She specialises in pituitary disease and metabolic bone disease, and is going to spend the next 15 minutes talking about the exciting world of clinical endocrinology and why we should never give up pursuing an interesting research question. She's also going to share some top tips on managing calcium problems. So Dr. Hyan, thank you very much for joining us today. I think you're muted at the moment, Dr. Hyan.
Yes, I'm just trying to unmute and get my video on. That's proving more difficult. There we go. Can you hear me now? And see me. Yeah, okay. So thank you for inviting me to follow on from Helen to talk about why I chose a career in endocrinology. So as Shazia has also already mentioned, I am a consultant endocrinologist at the Christie Hospital NHS Foundation Trust, which is in Manchester. It's actually a tertiary oncology hospital with a very small endocrine unit that I work at. So we have the luxury of not having an A&E, and so all of our work is essentially outpatient endocrinology work, which is a real luxury. And there is an endocrine department at the Christie because when the Christie was the first hospital to use tamoxifen in the treatment of breast cancer, and when the drug company that introduced tamoxifen, I think it was around 40 to 50 years ago now, decided they needed an endocrinologist to help manage this hormone treatment, and there's been an endocrinologist at Christie ever since. So that's the history of that. So why do I do endocrinology? Well, I've been asked before to give a talk like this, and if you're wondering what Helen's Twitter handle is, it's at hormone_doc, and I do recommend that you follow her for lots of top tips on endocrinology and teenagers and cricket mainly. So a couple of years ago, I was asked also to give this talk, and Helen was giving a similar one at the Royal College of Physicians. So she tweeted all of our colleagues, which is kind of an efficient way of gathering information in these days, and she tweeted and asked why other people chose endocrinology. So I was involved with this event, as I said, a couple of years ago, and actually what was very nice was this last week our registrars changed around. So we had a new specialist trainee starting last week who said that he came to the talk that I gave, the last one of these that I talked at, and that is the reason why he chose endocrinology. So that was quite a nice turn of events to have him now in our department. So Helen asked everybody, why did you all choose endocrinology? And these were some of the replies. So this was my very geeky reply: I can't resist feedback loops. And this is a picture of me. I look very different now. This wasn't actually all that long ago, although I look young and quite wrinkle free. I think that I may have not been a consultant for very long. And this is me now, when my hair is a lot longer and I spend more time sort of, socially distanced in forests, and with more wrinkles. So I said I can't resist feedback loops. We got a lot of other input, and I've just selected a few. So Dominic Cavlan, who's an endocrinologist in London at St. Bart, said that he felt that endocrinology was for him because it's more about actually understanding the processes than knowledge. So you can figure out things from first principles. So if that interests you, then endocrinology is definitely something to consider. David Ray, who at the time was actually with us in Manchester, has since moved down to Oxford, and Stephanie Balderwig, who works with Helen in UCLH, and Zaki Hassan-Smith, who's in Birmingham, all good colleagues, basically felt that they chose endocrinology actually because they were inspired by people that they had worked with, and that they still find people inspiring. So that's maybe another reason to choose it. There are people within our endocrine field who I think are pretty inspiring. Simon Pearce, who is a professor of endocrinology in Newcastle, he said, because once you've made a simple or occasionally mega smart diagnosis, and Simon's made, I think, quite a few mega smart diagnoses, you've nearly always got an effective treatment to offer. So I really like this about endocrinology, although because I work in a cancer hospital, a lot of patients who are coming to the Christie are undergoing treatment for cancer, and often one of the only things that we can manage and we can treat are their endocrine problems. So we can make these diagnoses and we can give treatments that make people better. And actually, in most of our clinics, patients are not dying on a regular basis. We're pretty good at treating the conditions we have. So there's some of the reasons why you might want to think about doing endocrinology, and you can see that they are different for different people, and really you have to kind of arrive at that decision yourself. But there's some of the aspects of endocrinology and endocrine conditions that you might enjoy. So just a little feeler for what I actually spend my day doing, because I think when I was a junior doctor, trainee medical student, I would often wonder what consultants did all day. And so this is just a little feel for how my week pans out. So I've actually got 2 days a week now which are funded from an MRC research, what's called a clinical academic research partnership. So I'm very fortunate to have 2 days a week which are purely research based. The other times I'm doing clinical work, so I have a general endocrine pituitary clinic, which is a very big clinic on a Monday. We have generally 3 or 4 consultants in that clinic. We have 2 specialist trainees, 2 CMTs, and often an academic clinical fellow, and we see about 60 patients or so every week in that clinic, and then have a sort of extensive post-clinic meeting to discuss all the patients. So we see all our patients with acromegaly and Cushing. So this is a fantastic sort of long-term pituitary clinic. On a Wednesday, I spend most of my time thinking about metabolic bone. I'm the clinical lead for the metabolic bone service, and report all the DEXA scans, run the DEXA service for the trust. And then on a Friday was where my heart lies, is with the bone and also with the late effects. So these are all patients, particularly the childhood cancer survivors, children who've had brain tumours, and their long-term follow-up in terms of their hormonal and psychosocial, just the whole care of these patients. So this is fascinating from an endocrine perspective, and Helen and I are actually the leads for the Living with and Beyond Cancer clinical network for the Society for Endocrinology, and so I focus a lot of my efforts on making things better for these patients. And then on a Friday afternoon we have all of our team meetings, research, clinical, nursing, catching up, cup of tea, biscuits, or we used to, we now do it on Zoom, socially distanced obviously. And then at the weekends I try to, this is me and my sister when we were at a meditation retreat just before lockdown, and this is me trying to keep sane during lockdown in our local reservoir, doing a sunset swim. So that's kind of how my week generally pans out. So just to go into some top tips, some things. So as I said, I run the metabolic bone clinic at the Christie. So this ranges from primary hyperparathyroidism and general hypoparathyroidism after cancer treatments, and then all of the various bone issues that you can get from cancer treatment. So it can be a very specialized clinic. So in terms of top tips, as I said at the beginning, I'm a geek and I love feedback loops, and I think if you're going to be an endocrinologist, then it helps to at least try to like feedback loops and at least to learn them. So if you're measuring anything in a patient who has any abnormality of their serum calcium, high calcium, low calcium, it's almost impossible to make a diagnosis or to determine what you need to do to treat these patients without measuring your serum calcium along with your PTH and your vitamin D, preferably all at the same time, so that you've got an overall picture of how your feedback loop is working. So try not to measure these things in isolation, try to measure them all at the same time, however tricky that might be. So that would be my first top tip, that to learn to love your feedback loops and then measure the right things. As Helen was already mentioned in her talk as well, if you're thinking about the adrenal axis, all of the endocrine systems have their own feedback loop, which should be interpreted by measuring all the various factors. So that's top tip number 1. So the second thing that I do, as I said, is I'm the lead, and I'm quite passionate about providing an excellent DEXA scan service. So this is actually, this picture just makes me laugh every time I see it. So this was when the Christie first had a DEXA scanner, there was much celebration, and this was around 2005 when I first started my clinical research fellowship at the Christie with Professor Trainer, who is here in the background. And for some reason, Trevor McDonald, who was a newsreader, for all of them those too young to recognise him, was at the Christie for that day doing something spectacular around cancer. And he was dragged into a room with our DEXA scanner in order to take a picture of our new DEXA scanner. And I got to be the model patient lying on the table. So it just makes me giggle every time I'm saying it's one of my only encounters with celebrity. So in terms of the DEXA scan, what would I suggest. So these are some top things to remember when you're interpreting DEXA scans, when you're thinking about patients' fracture risk. And this is, I think, useful for everybody because lots and lots of people fracture. It's one of the, the top issues in terms of hospital stays and cost to the NHS. So what we often think is that bone mineral density is the thing that's key for in terms of fracture, but what we can actually see is that this is only one of the things. So certainly as your bone density goes down, so your lower bone density here at the top, you are at increased risk of fracture, but also your fracture risk increases with age as well. So for example, having a bone mineral density score of -2.5 means different things at different ages. So fracture risk is not all about bone mineral density, and you shouldn't just automatically treat somebody because of their low bone mineral density. The other thing to remember is that although fracture rate increases, as in you're more likely to have a fracture the lower your bone density, actually most people fracture with a bone density that is in the osteopenic range. So we can see here that the highest percentage of fractures is actually when people have a bone density between -1.5 and -2, and there are different reasons for that. One is that we need to take all things into account when we're considering fractures, and also because there are more people who have got bone mineral density in this range. So again, bone mineral density fracture risk is not all about bone mineral density. And what we have to do is we have to take into account fracture risk. So think about the fracture risk, not the bone mineral density. And please learn how to do a FRAX score appropriately. So you can find the FRAX score, fracture risk score, on this website. And it's really important this is filled in correctly and that you fill in this section about the bone density. Please don't use the T-scores. If you've got the bone mineral density scan, please find out which type of scanner this is. So this is a hologic scanner, and what the actual bone mineral density is in grams per centimetre squared. Put that in and you'll get a calculation. So then you can press NOG guidance and that will tell you what to do in the UK, or you can go from absolute fracture risk. So a hip fracture risk above 4% and a major osteoporotic risk above 20% over 10 years is indicative of a high fracture risk, and these patients should be treated. So think about fracture risk, not bone mineral density, and learn how to do your FRAX properly would be my top tip number 2. And you can prevent a lot of people's suffering and even mortality, high mortality rates after hip fracture and vertebral fracture. So finally, the other thing that I spend a lot of my time doing when I'm not doing my clinical work is thinking about bone health in terms and cancer. So this is just a slide from the Endocrine Reviews article we've published a couple of years ago, where I wrote the bone section just to illustrate that cancer and cancer treatments can affect bone in a number of different ways. Overall, patients end up generally with low bone density and increased fracture risk, but there are lots of different reasons underlying this. And this is where I got my MRC funding, as to look at a very specific problem following pelvic radiotherapy. So lots of hundreds of, probably tens of thousands of patients get pelvic radiotherapy, and they particularly for gynecological malignancies, but also for prostate and colorectal malignancies. And this is just data showing that patients who have pelvic radiotherapy have quite a high incidence of pelvic insufficiency fractures, and that this has been persistent over time. So there's now over 3,000 actually pelvic insufficiency fractures described in the literature, but described mainly from an oncological perspective. So there are no data about the risk factors really for these fractures, no data about what to do once a patient has a fracture, how to prevent them and how to treat them. So what I have got funding to do is to investigate the use of a musculoskeletal health package. So actually looking at these patients' baseline bone health, and they will get randomized to either an observational arm or an arm where we treat their bone health with exercise and calcium and vitamin D and bisphosphonates if appropriate, and we will see whether we have any effect of that, when this will go on to inform a large UK multi-centre randomised control randomized controlled trial, sorry. So I spent a lot of time thinking about this. And the key thing here is that we should never really stop questioning. So a lot of the knee-jerk for treatment for patients who have a fracture is to start patients on bisphosphonates. However, when patients have had radiotherapy to bone, what happens is that the cells within the bone probably actually become underactive and stop working. The cells die off. That's how radiotherapy works. And therefore, you've got a situation where the bone is probably in a low turnover state, and therefore the possibility is that bisphosphonates, which actually work to reduce bone turnover, may actually have a negative effect on fractures in this situation. We don't actually know this because nobody has studied it, and this is what this project will go on to look at from a more translational perspective. So my top tip number 3 is that not all fractures are the same, and you do have to think about the underlying cause of any fracture that you see, and consider whether actually it does relate to osteoporosis and high bone turnover or not, and to get experts involved if you're unsure. And the second thing is just that this MRC funding, this project has come after a long period of interest in research. So I did a PhD a long time ago in 1996. I then did a bit of clinical research with Professor Traynor in 2005, and I've been starting to think about this project with the bone health since I started at the Christie in 2012. So it's taken a long time to get there, but persistence and following your interests is key. So just to summarize then, why do I do endocrinology all day? So I would have to say that I do it mainly for my patients, and this is one of my lovely long-term follow-up patients after having had childhood brain tumor, and he's aware that he is a model for my talk today, so he's very happy to share his picture, and that is overall the main reason why I do this job. The second reason is all of my lovely colleagues, and this is one of our Friday afternoon meetings before coronavirus, where we all sit around and discuss all the patients, interesting cases, any issues, and that's fantastic. Of course, I have to say that I do love a feedback loop as well from an intellectual basis, and just the opportunity to follow my interests in terms of research questions and trying to get good clinical outcomes for patients. Thank you very much.
Brilliant. Thank you very much for that fascinating talk, Dr. Hyan. So just a reminder to our attendees that if you do have any questions related to metabolic bone disease or late effects of cancer treatment on bones, that you would like to use this opportunity to ask Dr. Hyan, or anything else that you want to know about her very diverse working week, then please do pop a question in the chat box and I'll direct them towards her at the end of the session. And just moving on to now our final speaker of the session today, Dr. Carla Moran, who's currently working in Dublin as an endocrinologist. She has spent the latter part of, or the more recent years, completing a fellowship in thyroid disease at Addenbrooke's Hospital and Cambridge University, where she's had a huge role in setting up the thyroid services and leading the thyroid services there, and has also dedicated time in designing the referral services for unusual thyroid function tests. So I'm sure we've all seen some odd thyroid function tests in the past, but I'm sure Dr. Moran has seen them all. So she's going to spend the next 15 minutes talking to us about why she chose endocrinology, and is going to tell us why it's such a fantastic career choice and give us some top tips on managing funny thyroid function tests. So Dr. Moran, thank you very much for joining us all here today.
Great, thank you very much, Shaz. So hopefully I will be able to share my slides. Okay, so hopefully everybody can see those. So thanks so much for everybody for dialing in. I'm going to share with you why I think endocrinology is a great specialty. And like the others, I'm going to start off with my journey and how it all started for me. So I was the first person in my family to go to university, and we'd no doctors in our family, but I was really keen to study medicine. And so I studied medicine in University College Dublin, which is one of the largest universities here in Ireland. And from very early on in my career, I was very clear that I wanted to be a physician, and I had no interest in surgery whatsoever. So once I graduated, I chose medical specialties, and so I did the equivalent of core medical training. And then I was accepted onto the specialty registrar scheme here. And so at the equivalent of ST6 stage, I was interested in doing some research. And so I was awarded a bursary to do 1 year's research in Cambridge. And so this is a photo of me when just shortly after I had arrived in Cambridge in 2011. And I'm with another endocrinology friend of mine, Rachel Crowley, who also trained in the UK and now is working in Dublin. So a year later, I was awarded my certificate of completion of specialist training from the Royal College of Physicians in Ireland. And I stayed on to do some more research because it was going well, and I was awarded a PhD in 2014. And I got married around this time, and I had one son and later had another. And soon after my PhD, then I was appointed as a consultant in Addenbrooke's Hospital, as Shaz has said in the introduction. And I was there for 5 years, and I led the thyroid services there and did lots of different elements of the thyroid services. And then last year I came back home to Dublin, and now I work in the Beacon Hospital, which is a teaching hospital on the south side of the city. So why did I choose endocrinology? And I think I'm going to tell you my thoughts, but you'll see some very similar themes. So I was also inspired by a team. So I was attached to, when I was an SHO, to a really great endocrinology team. It was really big. Everybody was really enthusiastic. Everybody seemed to know lots about endocrinology, and they were keen to share their knowledge. And the consultants were really approachable and very supportive. And that really inspired me to want to be an endocrinologist. And I also had the impression that endocrinology seemed a very erudite specialty. So all of the professors seemed to be endocrinologists, and they knew all about endocrinology, but they also knew all about general medicine. And they seemed to be excellent diagnosticians. And so often we'd be asking for an endocrine consult, and we wouldn't quite know what we were asking for, but we thought that endocrinologists would be able to get to the bottom of it. And still now I get an endocrine consult that just says, please see and exclude any endocrinopathy, because nobody else seems to be able to investigate it in any way. And one of the other things that I really liked when I was training in medicine is looking after endocrine emergencies on call. So I would be the person who would volunteer to see a young patient with DKA. And I loved the fact when they came in, they were really unwell and their biochemistry was completely abnormal. But then over the course of my shift, I could get them to a point where actually they were sitting up in bed and asking for breakfast. And I loved seeing their physiology change and improve over the course of a very short space of time. And something that I really still enjoy now is that interface between physiology and laboratory. So to be an endocrinologist, and you've heard this already, I think you have to really know your physiology really well. And you also have to very clearly understand what tests you're requesting and also how to interpret those tests. And the cases that I've chosen to share with you, I think illustrate that. You've heard also that we treat chronic conditions. And I think certainly as a consultant, not so much when you're training, but as a consultant, you end up seeing the same patient multiple times a year for many years. And you develop a great patient rapport, and you end up seeing them through various changes in their life and get to know them really well. And that's very satisfying. And the other thing is that we can treat pretty much everyone. It's really unusual for us to give a really bad diagnosis. And if we do have to give a bad diagnosis, we can usually still offer some treatment. And I like that a lot. And the other thing, and this is in the interest of being honest, is that I felt it was a rather clean specialty. And I didn't really want to be involved in bodily fluids or scoping or surgery, etc. So I liked it for that reason. And the other thing to say is I had in my mind, perhaps that I wanted to do anesthetics, but I soon realized that actually, if I did anesthetics, I would be made to get up out of my bed at 3 o'clock in the morning, probably on a regular basis until the time I retired. And I didn't really want that. So Claire has shared with you her timetable, and there will be similarities. And so this is my timetable, but don't obviously have to look at the details, but the things to take from it is that we spend a lot of time in direct clinical care. So we do a lot of clinics. I do 4 clinics a week. I may end up doing more. I do a lot of ward rounds. And the other thing we do an awful lot of is admin. But no matter what medical specialty you choose, you'll be doing a lot of admin. And of course, we also do teaching, management and governance is very important. And depending on your role, you'll participate in research, whether that's just audits or whether that's in a more formal way, like Claire showed you. So when you're choosing your specialty, don't just think about now and the training. Think about whether you want to do this for 30 plus years, because that's potentially how long you'll be doing it for as a consultant. So I'm going to go into my cases, and first I want to remind you about pituitary function. So you'll know that the pituitary is under control of the hypothalamus, and you'll know also that the pituitary makes a number of different hormones which are listed here. And most of those hormones then act on another gland to stimulate the production of other hormones. So TSH stimulates the synthesis and secretion of thyroid hormones, T4 and T3. ACTH controls the release of glucocorticoids and androgens from the adrenal glands. LH and FSH control the function of the ovaries and the testes. Prolactin enables breastfeeding after delivery. Growth hormone is, of course, very important in childhood, but it's also an important anabolic hormone in adulthood. So bear that in mind when I go into my first case. So this is a woman that I saw recently. So she's 34 and she presented to A&E. And she was complaining of an awareness of an abdominal pulsation. This is not her photograph, but it's a representative photograph of a similar patient. And A&E thought she might have a AAA. So she had an ultrasound of her abdomen and then she was discharged. But she went back to her GP because, not surprisingly, she still felt really unwell. She had palpitations, tremor, poor sleep, weight had been stable, and she had a family history of thyroid disease. And the GP detected a goiter and tachycardia. And the GP requested the correct test, which were thyroid function tests. And he found that her T4 was very raised at 56, free T3 very raised also at 22, and TSH appropriately completely suppressed. So this lady clearly has thyrotoxicosis. And I'm sure you know that it would be very unusual for a 34-year-old female non-smoker to have a AAA. Much more likely that she might in fact have palpitations related to thyrotoxicosis. So my first tip is to think of endocrinology and also to request the right test. So I think most of you will be able to detect that somebody has thyrotoxicosis, but really now, because you're budding endocrinologists, hopefully at this stage, the next step then is to find the cause of the thyrotoxicosis. And so I've listed here the common causes. So Graves' disease, as you know, is an autoimmune condition, far more likely to happen in women, usually women of childbearing age, and they often have a smooth goiter. Another common cause is a toxic multinodular goiter or an adenoma. And this is where there are one or more nodules in the thyroid gland that autonomously produce thyroid hormones. These patients can often have a nodular goiter, but you may not feel anything on examination. And the third common cause is thyroiditis. So this is inflammation of the thyroid gland, either due to medications or virus, or sometimes autoimmune disease as well. And in all of these cases, patients will have a low TSH, a raised T4, and a raised T3. A TPO antibody is the most common antibody that's requested in this situation, and it's almost useless. And what I want you to do now when you see your next person with thyrotoxicosis is to request a TSH receptor antibody, because this test is fantastic. It's really sensitive and it's really specific. So if you have somebody who's thyrotoxic and has the positive TRAB, they have Graves' disease. And if they have a negative TRAB, it's really unlikely that they have Graves' disease. So start going to step forward, I think, and request a TSH receptor antibody for your patients who are thyrotoxic. And this lady had a positive TRAB, and so she was treated for Graves' disease with antithyroid drugs. The next case is a 77-year-old male who had a history of metastatic melanoma, and he was fatigued and dizzy, and oncology contacted my team because they were concerned about hypothyroidism, but they had done a TSH which was normal. Now, by and large, the first test for thyroid function will be TSH. And in many cases, it will be sufficient. However, TSH is a great test to look for primary hypothyroidism. In other words, thyroid gland failure, most commonly due to Hashimoto's or post-thyroidectomy. But if you're thinking about secondary hypothyroidism. And by that, I mean that the thyroid gland has failed because there's no signal from the pituitary gland to stimulate thyroid hormone production in the thyroid gland. Then you need to do a full panel. So you need to do TSH, T4, and T3. And what you'll find is that the T4 and T3 are low, and the TSH is in the quoted reference range, but it's inappropriately normal. That TSH is inappropriate for a low T4. Your pituitary should be saying to the thyroid gland, make lots of thyroid hormones. So the TSH should be 100 or certainly very elevated. And this concept of being inappropriately normal is based on the feedback loops that you've heard of, many of us mention, and it's unique to endocrinology. But it's very important. So it's very unusual for somebody to just have TSH deficiency and not have any other hormone deficiencies within the pituitary gland. So when we suspect pituitary disease, we measure all of the pituitary hormones. And so for him, we measured ACTH and cortisol, and they were undetectable. His testosterone was really low. And again, his gonadotropins were not elevated. So again, they're inappropriately within the reference range. Prolactin was low. And you'll notice that I didn't measure growth hormone because that's released in a pulsatile fashion and on occasion can be very low in a normal person throughout the day. So instead we measure IGF-1, which is a protein that's made in the liver in response to growth hormone. And that has a much longer half-life. And you see that that's low, and that's consistent with growth hormone deficiency in this setting. So this patient had hypothyroidism. He had an MRI scan, it showed hypophysitis, so inflammation within the pituitary gland. And his treatment is hormonal replacement. And another top tip is that if a patient needs replacement of glucocorticoids and thyroid hormone, always replace the steroids first for a few days before you start thyroid hormone. Because if you start thyroid hormone by itself initially, you can precipitate an adrenal crisis. So practical tips for TFTs: think of endocrinology as a differential diagnosis, or you might miss the diagnosis. Request the right test and know how to interpret it based on physiology. And be aware of this concept of being inappropriately normal. Hormones are very dynamic. Many of them change throughout the day. They change depending on your physiological status, so whether it's growth or puberty or pregnancy. And sometimes a normal hormone would be outside the reference range. So it would be normal for your TSH to be very high if your T4 is very low. And the best test for finding the cause of thyrotoxicosis is TSH receptor antibody. And so request it the next time, and your endocrinologist will be very impressed. The other thing I would say is clinic is really where all the magic happens in terms of endocrinology. Inpatient cohorts of endocrine and diabetes patients are very different to the cohorts of patients that you will see in clinic. So if you're thinking about endocrinology and you've never been in an endocrine clinic, definitely go down and sit in an endocrine clinic. And this is my last slide. I've stolen this graphic from Wikipedia because I really like it. And what it shows is the various substances that are present in the bloodstream. So at the top left are substances present in picomoles per liter, and you see these are hormones. And then as you go along, you get to millimoles per liter. And these are things like bicarbonate, potassium, and so on. And so in the millimoles per liter is where your nephrologist hangs out. And in the millimoles per liter is also where your cardiologist hangs out, because this is cholesterol, triglycerides, and so on. And then as you go down and down and down, you'll find your endocrinologist. And hormones are present at billion-fold lower concentration than all of those things that are present in millimoles per liter. And it fascinates me that they're present in such low concentrations, but they control everything. They control our growth, our puberty, reproduction. They control our body composition, our well-being, and they have a role in the function of all other organs. So I hope that you're inspired, and I hope you want to be a super doctor, and I'd love for you all to join us as endocrinologists. Thank you very much.
Dr. Moran, thank you very, very much. What an absolutely fantastic talk, and what a fantastic way to end or bring to a close our webinar series today. There are some questions that have appeared in the chat box, what I'd please continue to keep your mics off for now, and then I will direct questions to you. So there's a few clinical questions and then a few sort of training pathway related questions. And if I could start by asking Dr. Simpson first. So earlier on, one of the attendees asked about the risks of central pontine myelinolysis in the management of hyponatremia. Have you got any top tips for our junior colleagues with this regard?
Yes, thank you. I realise I kind of skimmed quite fast over that. So I'm sorry if I wasn't clear. So this is a really important point, actually. And it's also really important to bear in mind that the same happens with a very high sodium. So we've seen this in a patient with COVID and hypernatremia as well. So if you're looking at shifts in the brain doesn't like rapid shifts of sodium. So when you're changing when we're treating our patients, we should be looking for only a 10 millimole change basically of sodium in 24 hours. So that's why we go quite carefully, we go cautiously, and sometimes it's coming up too quick. We give sort of rescue fluids to try and slow down the rate. So if you look at the paper in Endocrine Connections, that kind of goes through that quite nicely as well. And again, as I say, my top tip is look at this for both a low sodium and a high sodium. Don't correct it too quickly. And also, if you've got severe high or low sodiums, ask a friend, get some expert advice, or get an endocrinologist involved, because it can be a little bit tricky. Don't manage it on your own.
Brilliant, thank you very much. So the next question is directed at Dr. Hyan. So there's two questions actually for you, Dr. Hyan. The first is, does it matter which vitamin D is checked? When you talked about measuring the calcium, PTH and vitamin D, which vitamin D should we be requesting? And secondly, who should be calculating FRAX scores in patients? And if it's calculated through during a patient's inpatient stay, what should you do if the FRAX score is high?
So in terms of the vitamin D question, I think most laboratories measure 25-OH vitamin D. You can get 125 measured but that's in specialist laboratories. So most labs will measure 25-OHD, and most will measure, I think, a combination of vitamin D2 and D3, where most of it is D3. So that would be what I would be asking for. But when you request vitamin D through any NHS service, you'll be getting a 25-OH vitamin D, I think. In terms of the question about who should measure the FRAX, I think everybody should measure FRAX. Everybody and anybody can measure a FRAX and do it properly as best you can, because it really is. I think there was something on from the International Osteoporosis Foundation that I retweeted today that was something about I think 80% of opportunities for patients after they've had a fracture to prevent further fracture are missed. So it's a huge problem. That's globally, but I think in the UK there is still a fairly big issue. So we miss a lot of opportunities to treat patients with fractures. So anyone can do a FRAX. If you measure it and the FRAX is high, and the patient is an inpatient, which I think that's what that question was about, then it should. I think you could very easily put that on a discharge summary to ask for the GP to follow it up, to consider starting oral bisphosphonates or whatever is appropriate, because that may not be an appropriate thing to do in hospital, but certainly to flag it up, I think, is everybody's responsibility.
And how do you replace vitamin D in patients who may be hypercalcemic in the context of primary hyperparathyroidism?
So most patients who have primary hyperparathyroidism will end up with a low 25-OH vitamin D because PTH stimulates the conversion to 125. So I always measure vitamin D because it's important and part of the diagnosis. As I said, you need all of those things to make the diagnosis. People often worry about giving vitamin D back to people who are hypercalcemic in the context of primary hyperparathyroidism, but there's quite a lot of evidence that it doesn't massively drive up your calcium. In fact, sometimes it can even reduce your calcium because of the drive of the low vitamin D. So I always replace it. I used to give big high doses of vitamin D. I tend to now give 800 international units once a day, and that often does the trick. And I do, if they've got particularly high calcium, I will recheck it after 2 weeks, 3 weeks. But otherwise, I replace most of my patients with primary hyperparathyroidism with 2,800 international units once daily of vitamin D.
And a question for Dr. Moran. Would you use the TSH or the free T4 or both as a marker of thyroid hormone replacement in patients on thyroxine?
So I think it's fine to use TSH alone in that setting. One thing to say is that if you measure both, what you'll often find in patients on exogenous thyroxine is that their T4, in order to get the TSH into the reference range and sometimes into the lower end of reference range where some patients feel better, you might end up with a T4 that's slightly elevated, but don't worry about that because the T4-T3 ratio is abnormal or certainly not the same as in normal physiology in patients who are replaced with exogenous thyroxine. So TSH alone is sufficient, and if you do request T4 and it's a little bit elevated, but the TSH is within the reference range, I wouldn't worry about it. Go by the TSH.
Brilliant. And then I think I'm going to make this the last clinical question before we move on to some specific training related questions. And this is for you, Dr. Simpson, is how do we calculate the corrected sodium in patients with hyperglycemia? Any tips?
I was dreading this. I saw this in the chat. I thought, please don't ask that. Please go on to training questions. I don't really correct it now. So I think this was slightly in the olden days when you had flame. I can't remember the method, but it was flame spectroscopy for calculating sodium, and you could get a pseudo hyponatremia if you had other osmoles in the serum or the plasma. And so these days we don't correct it so much because it's not as the results are much more accurate. I'm trying to think if I had a patient with a very high sodium, then a very high glucose, whether I would, and there may be an error there, but it isn't something that's really an issue now with the more modern machines and the way sodium's measured. I hope I'm right. I think Claire will correct me.
I think also most of the calculators are pretty inaccurate.
Yeah.
So I think mainly the key is to just do things slowly and keep a very close eye in a highly monitored environment, because whatever calculation you make, there is quite a lot of error within it. So you can't just guess, change something and then recheck. You need to just be carefully rechecking, I would say.
Look, and just related to the rechecking again, so again, a top tip, because I focus a bit maybe on adrenals, but just the other top tip is just look when you're on call and when you're working, the difference between the VBG machine and the lab sodium as well, because that changes. So whatever you're looking at and you're tracking, so you should be checking these patients with severe high or low sodium every hour, every 2 hours. You really got to be following them closely when you're at the severe end, and make sure you keep it consistent. And I'd recommend you kind of get you look at your trend on the lab or the VBG and point of care. So what I mean is point of care, because the results can be slightly different. So just be a little bit careful. It can change by sometimes 5 millimoles. So be careful what you're tracking, because you don't want to get a big swing either way that's from an inaccurate result.
And one of the attendees has asked a really important question, which I think is probably relevant to most of the attendees and higher level trainees as well. And that's regarding how much time you spend doing on-call acute or general medicine if you're on an acute rota. So I guess it'd be useful for you guys to share if you are actually doing any acute medical on-call work, and if you are, how often you would commit towards that.
I think we might all be a little bit sheepish here. We've obviously differentiated in a quite similar way, actually, reflecting on the talks, in that I didn't do any acute medicine, general medicine anymore. I did when I was at Cambridge as a consultant. I didn't do a lot, but I did some. And actually, I think it's still really important to be very holistic, but because we're all a bit more differentiated, we're now in jobs that really predominantly focus on endocrinology. And
yeah,
I saw a question, sorry, Claire.
I was going to say, Carla, I don't do any diabetes or general medicine. So as I said at the beginning, I work in a tertiary oncology hospital. So I do cover the endocrinology, specialist endocrinology and inpatient diabetes, but I don't do any diabetes or general medicine anymore. But I did dual accredit. Carla, did what?
Yeah, same for me. I don't do any acute medicine. I do inpatient endocrine consults, but I do, for my fellowship, I did a lot of endocrinology, but now I do endocrinology and diabetes in clinics and in inpatients, but I don't do any acute medicine.
I think the key to trainees that are interested in pursuing endocrinology and diabetes is not be put off by the prospect of doing acute or general medicine, because it may I mean, I do general medicine, I very much enjoy it, but it may not be a part of your working rota as you progress through your higher levels of training in your career.
And the other thing actually I just say about general medicine is, you know, obviously I trained and did a lot of general medicine, and actually it really stands to you. Even if you don't end up doing it, it's really helpful to have that, because then you can treat other things when you're in your clinic, like straightforward hypertension and dyslipidemia and all, you know, all of the chest infections, etc.
And we're very multi-system. I think we've all said that hormones control everything in a way. We're very multi-system in endocrinology, and I think it's really good to have that holistic, you know, I'm a different era. I was before European Working Time Directive, so we did 24-hour shifts and all the rest of it. But I still learned loads on call, and I really don't regret my general medicine at all. I think it really gives you a good grounding as a physician.
There's another question by somebody who's obviously very keen to pursue an academic pathway, and they want to know if there's any tips on how to pursue a research career and get involved in multi-centre trials.
Claire, maybe?
So I think that very much depends on where you're up to currently, but if anybody's interested in research, then that's brilliant, and I would continue that interest. I think the first thing to do is to speak to the people that you're working with, the team that you're working with, and approach the endocrine team if it's particularly endocrinology, and see what research they have got, you know, going on, and try to get involved in any small way. So we invite all of our trainees to do their ICH GCP, which is what you need in order to participate or help with any clinical trials, and that's available online through the NAHR portfolio and NAHR website. And then we try to utilize, so our specialist trainees can be part of our commercial clinical trials, and they can be sub-investigators on those trials to review patients and start to get a feel for research in that way, and that gives you a bit of experience about what it might be like. And then if you want to pursue research, I guess it's about talking to people locally who have research teams and research projects ongoing about looking to get more of an academic career. But I tell you that people will bend over backwards to try to help you to establish these kinds of careers. So please just go and ask, talk to people. Don't be afraid of going to speak to people who are doing interesting things, or if you've got an interesting question or you think you want to answer something, just go and have a chat with people. Everybody is inherently nice and will want to help you.
My next question isn't actually something that's been raised by any of the attendees. It's a personal loaded question. I speak on behalf on trainees that may not want to pursue an academic career. Is it a prerequisite to want to pursue a PhD or an academic career? Is that what you need to become an endocrinologist? Or could you become an endocrinologist if you were not research or academia inclined?
I think absolutely. And I think absolutely. I think it's important to have a love of endocrinology. So I loved doing my in vivo physiology from that graph. I really, really enjoyed it. But I think if you didn't want to do a PhD or something, it'd be really good to show that you loved something about it. So whether it's a patient safety thing or a QI initiative or something like that, you just got to show that you love it, that you've got initiative, that you want to go off and do something. So it absolutely doesn't have to be a PhD. But if I was, you know, if I'm sitting there looking at people who are applying for jobs, I just want to see somebody who enjoys what they're doing and they're really going to get stuck in at some way. And if it's a little bit different, then that's also totally cool.
And just for the trainees out there, I'm a specialist trainee in London. I've not done a PhD, so I've not sort of followed the path that my colleagues here have followed, but I have pursued other areas that I'm very much interested in. So that includes medical education and leadership. I very much, as Dr. Simpson and the other speakers have said, love my job and do it mainly for my patients. And so do not be put off if you do not want to do a PhD, because there are certainly other options as well as clinical related PhDs as well. Is there an option for a run through in specialist endocrinology alone? And if you do dual credit, if you do credit with diabetes and endocrinology, how likely are you to have a job that is pure endocrinology rather than diabetes and endocrinology as a consultant.
I don't know.
I think there are very few jobs actually that are pure endocrinology. So I don't want to disillusion people, because I don't think there are very many jobs. So most jobs will be a combination of diabetes and endocrinology, and will probably have general medicine as well. But I don't think that detracts from the fact that there is endocrinology in there, and that all of the endocrinology you do in the endocrine clinics is fascinating stuff. So I think there are only very few pure endocrine jobs, would be my feeling. I don't know, Carla, do you?
Yeah, so there are very few pure endocrine jobs. If you really wanted to pursue that, I think you could. But I've kind of seen it from both sides. So I've worked in the kind of, purely doing almost only thyroid medicine. And now I'm doing something that's much more varied. I'm doing a bit of everything. And actually, there's lots of good things about doing lots of different things. And sometimes if you choose something that is, very subspecialized, and you only do that, after a while you become de-skilled in the other things. And that sometimes is not very satisfying.
Yeah, and I would definitely discourage solely training in endocrinology. I think it is in theory possible, but I did endocrinology, diabetes, acute medicine, all the way through to being a consultant, and I wouldn't recommend. I think it becomes very difficult to get a job if you start cutting that down. So I really wouldn't recommend cutting down your training in terms of that. I would recommend getting to the end and having accredited in all of three.
And I suppose the thing to say, which actually I totally forgot about in my journey, because I can't even remember when I decided I wanted to. I mean, my PhD was in type 1 diabetes, looking at growth hormone, IGF-1, and insulin metabolism and physiology. But I knew I wanted to be an endocrinologist. And I, like the others, I did general medicine, endocrinology, diabetes. And then I went to Barts actually for 4 months. So Professor John Monson actually arranged for a free transfer. And I did just pure endocrinology at Barts, because I knew I wanted to do a finishing school, if you like, as an UP. I never worked abroad. But I knew that's what I wanted to do. So I went to do that and got all those endocrine skills. And then I got the job in Cambridge that I started off as at consultant level, was just a 3-day-a-week job. So I took a punt. So I think the other thing is I don't see myself as a risk taker, but in a way I took this risk. I just went off. It wasn't a substantive post. And then I ended up being substantive, and I still am. So I think sometimes if you really want to do something, then just don't be put off. Just get yourself in the best position, get the most experience that you can. And if there's a little opportunity or a big opportunity that maybe is a little bit different, then just go for it if that's what you want to do. Because so there is ways of kind of working it out, just maybe a bit more bendy than you might see otherwise.
My last question is, if you guys were considering a career in diabetes and endocrinology today, what tips would you give your younger self on, or how would you plan your future career and the next steps that you would take to set yourself up for a career in endocrinology and diabetes?
So I'll start off. I think, so the first thing I would definitely come back to going to clinic. I think going to clinic is really important, because if you've only ever seen endocrine and diabetes patients in hospital, it's completely different. So I would say go and sit in clinic. And the other tip I would give in general is, I think if you turn up and you're reliable and you're enthusiastic and you're willing to learn, you already have a head start on everybody else. And the other thing that I would definitely say to people is that if you're approaching an endocrinologist and maybe you want to go, say, in a consult ward and you want to learn something, like for me, if I meet somebody and they have maybe reviewed a case and come to me thinking about what's going on, what's the physiology, and they've already started to try and look after the patient themselves, that is such a huge head start, and everybody can do that, and it's so impressive. So I think definitely do that. And then in terms of me, what would I say for me? I would say I think probably in some ways we should be easier on ourselves, because I think when we start off, we feel like Helen says, you have to go on this one path and you have to do these things. And actually, you know, you'll get there in the end. If you're professional and good colleague and good to your patients and you have some enthusiasm and you're willing to work hard, you will get there in the end.
Yeah, I was going to say, I think I would have told myself to relax a bit, swim more in outdoor spaces, and just I think the two things are not being afraid to ask people and not assuming that you're in any way a burden to anybody. So just go and talk to people, show your enthusiasm, ask questions, follow what you're curious about, and always just keep the patient at the center of everything you do, and you're not going to go wrong.
Yeah, I agree with all those things. I think what Claire says, not worry, don't put too much pressure on yourself. I think you know, life isn't linear. Stuff happens to all of us outside of our work life as well, and this will affect things. I know we haven't, as I was saying to the others earlier, do not talk to me about work-life balance, because I am absolutely the worst person to talk to. But I think we just have to be kind to ourselves, because stuff will happen outside of our work lives that will impact what we can do and give to work. But if you're enthusiastic and if you show that you're really keen and interested, then you will find you will be successful and get whatever success means, and you will get to where you want to be.
Brilliant. So I just want to close off the webinar series now by thanking our three fantastic speakers, Dr. Simpson, Dr. Hyan and Dr. Moran. Thank you very much for giving up your time to inspire our future generation of diabetologists and endocrinologists. I'd like to thank the organisers, so the Society for Endocrinology and the YDF team for supporting the taster events. And lastly, thank you to all of the attendees for joining us today. I hope you found the sessions really useful, and I hope that you'll sign into the diabetes side or part of the webinar series on the 15th, so in 2 days' time, when you'll hear from some very inspiring colleagues that I work with in the field of diabetes. So thank you all very, very much.
Thank you, Shaz.
Bye-bye all, take care. Stay safe.